Hello class, today I will be talking about case number 15's dental hygiene care plan regarding periodontitis. This presentation is by Irel Hart and Cielo Sunnydad. Here is our table of contents, which will show you what we will be talking about during our presentation. But first, let me introduce you to our patient. He's a 65-year-old Caucasian male who is a retired bus driver. His height is 6 feet and he weighs about 220 pounds. He had a stroke about 8 years ago that unfortunately caused him to have a slurred speech, and his wife claims his breath stinks, and it's been 3 years since his last dental visit. Here we have the patient medical's history. He had a stroke about 8 years ago, which also caused him to have reduction in his salivary flow, and he's been a smoker for over 40 years but quit 2 years ago and feels so much better now, but he does miss smoking when he occasionally has a drink. His INR reading is 2.5, which is within normal limits for us to treat him. His vital signs include his blood pressure is 130/80, his pulse 72, his respiratory rate 18, and he does take medication, which includes Vasotec, Coumadin, and Lipitor, but they don't have any dental implications. Moving on to the question, his BP is 130/80, his pulse 72 beats per minute, and his respiratory 18 breaths per minute. What would you classify this patient as? A, ASA1, B, ASA2, C, ASA3, or D, ASA4? If you answered B, ASA2, you are correct. His BP is 130/80, which would classify him as ASA2 because of his elevated blood pressure. Moving on to his dental history, he does have previous periodontal therapy, which includes scaling and root planing, tobacco stains on his teeth. He brushes twice daily with a hard toothbrush using the back and forth scrubbing motion and flosses occasionally. He occasionally also uses mouth rinse because he hates the burning sensation. Moving on to the extraoral examination, he doesn't have no palpable lymph nodes, thyroid is normal, his face symmetrical, and no TMJ or any abnormalities noted. Looking at his study models, we would classify him as a class 1 because due to this, we see that the mesio-buccal cusp of the maxillary first molars occlude with the mesio to the buccal groove of the mandibular first molars.
During the intraoral examination, we assess the lips, cheeks, tongue, and pharynx to be all within normal limits. There are marginal signs of inflammation, visible supragingival calculus, as well as recession. Both maxillary and mandibular free gingiva, as well as the attached gingiva, appear pink, firm, knife-edged, and stippled. The maxillary free gingiva presents with generalized inflammation. Here we'll notice the heavy tobacco stains and visible supragingival calculus on lingual surfaces of mandibular anterior teeth. Patient is missing all wisdom teeth as well as all first premolars. There are also several amalgam restorations on all 4 quadrants, generalized recession on facial surfaces of most of the maxillary teeth and buccal surfaces of the mandibular teeth. Gingival tissues present with marginal signs of inflammation in lingual regions. As we look at his periodontal charting, we can see that he presents with generalized moderate bone loss with localized severe bone loss on the mandibular left posterior and maxillary right posterior, especially on areas of tooth number 20 and 29. Generalized pocket measurements of 1 to 6 millimeters on posterior teeth and localized 1 to 4 millimeter pockets on anterior teeth. Clinical attachment levels have been measured between 1 and 8 millimeters. There is generalized recession on facial surfaces of most of the maxillary teeth and buccal surfaces of the mandibular teeth. Radiographically, we see tooth number 19 has a defective crown restoration with an open distal margin and the presence of gingival recession. No visible caries present upon intraoral examination, use of ODU 1112, or radiographic evidence. Here you'll notice radiographic evidence of bone loss, as well as furcation involvement on tooth number 19. Not seen here is the furcation involvement on tooth number 3.
Moving on to his treatment plan, Based on our reviews of his vitals, medical history, dental, and periodontal assessment, the patient has no immediate emergency needs and have determined the best course of treatment is to treatment plan full mouth SRPs with localized anesthesia to maximize comfort and reduce pain during treatment. Based on his INR reading of 2.5, no medical clearance is required, and our appointment plan will require 6 visits to complete, including initial consultation. For his bad breath, we would recommend him toothpaste and to drink more water to help his halitosis and to increase his salivary flow. To help him relieve that burning sensation, we would recommend him a mouth rinse with no alcohol, such as Colgate Peroxyl. Regarding his oral hygiene instruction, we would recommend him a soft bristled brush using modified Bass technique, placing the toothbrush at a 45-degree angle, brushing each tooth using a gentle circular movement. We would also refer to his DDS for his crown number 19 redo. Question time. This patient will need a polish. What appointment do you think we should schedule it? A. Appointment 1, B. Appointment 3, or C. Appointment 6? If you answered C. Appointment 6, you are correct. This patient will need a polish at the last appointment once everything is all completed.
Each appointment will entail review of medical history, checking vitals, EOIO examination, oral hygiene instructions, and post-operative instructions. The initial appointment is for assessment purposes only. Appointment 2 will entail scaling and root planning of the lower left quad, as this quad is the most periodontally involved with the highest combined clinical attachment level, probing depth, and furcation involvement on tooth number 19. Local anesthesia will be administered prior to treatment at each appointment. No contraindications of medications have been noted. We will proceed to appointment 3 for scaling and root planning of the upper left quad. Appointment 4 will be for scaling and root planning of the upper right quad. Finally, during appointment 5, we will complete scaling and root planning of the lower right quad. Each appointment will have 1-week intervals. Appointment 6 will take place 4 to 6 weeks later for probing, calculus check, fluoride, and selective polishing. Patient will then be placed on a 3-month periodontal maintenance recall. That concludes our presentation. Thank you for watching.